Okay, it's recording now. The Parkland formula has 2 questions and then the rule of 9s. So instead of the exam being 60 minutes, it's 70 minutes. So that way you have time to do the math.
And we can have a piece of paper, right? Just show
Yeah.
it in the...
Yep, just show it to the, what program is it? Respondus. Before you start your actual exam. And that's in our exam instructions. So you won't be like flagged for cheating or anything. Okay. So say you're the ER nurse and a burn comes in and it's an inhalation injury, a suspected injury. What is going to be your priority assessment? What are you going to do first?
Airway. Check their airway.
Airway.
Okay. Sorry, I'm trying to keep the chat here in my view as well. Okay. What is an escharotomy?
That's when they like cut your arm or your leg, right? Or they get rid of the eschar. I'm off. Someone else answer.
That dark bloody layer is superficial.
They're opening up the skin to allow that pressure to release.
Treatment for compartment syndrome.
Wheels turning. So, how deep does an escharotomy go?
Does not go to the muscle.
fascia.
Superficial.
Would it be to the fascia or fascia? I might be saying it wrong.
No, not that one. Not that deep. Just a little bit above that one. Alex got it, the sub-Q. So escharotomy goes down to the subcutaneous layer of fat to allow for expansion of swelling for prevention of compartment syndrome. Then, here's what I found. Oh, I turned my watch on. Whoops. The fasciotomy goes down to the fascia, and that's all the way to the that little silver lining of the muscle. That's the difference between the escharotomy and the fasciotomy. Somebody has a puppy? Where? Oh, I see it now. That's a tiny puppy. Is that a wiener dog? Is that
yeah, she's a mini wiener dog.
A mini one. Okay. What fluid do we use for burn resuscitation?
Lactated ringers.
Yep. And then what fluid do we use for shock?
Normal saline.
Normal saline. What's your fluid resuscitation rate for shock patients? What's your math equation?
30 per kilo.
Tell me about how you manage oh shoot, I can't say too much more than that. Let's talk about pain control in a burn. What should we do during the admission process? What kind of pain medications would we give? Oh my gosh, you guys are going so fast. So during the admission process, and we're scrubbing them down, and we need to assess them very quickly. Terry says IV. IV what? Morphine?
Like heavy stuff. Dilaudid, morphine, Fent.
Yes, all of those. Then after they're in the recovery phase, that's when you would progress to the orals. And the rationale behind that is when you're being scrubbed down and your skin is gone, it hurts. And we need to give something that happens very, 1 to 2 minutes for that duration or the onset. But your Percocet, you would want to have around the clock and then save your IV stuff for breakthrough pain. We also give our pain meds during dressing changes, so about 30 minutes before a dressing change. So that way the patient tolerates it. And then we would teach that to the patient when they're going home, because we can do the teach back method and have them be able to do their own dressings or have their partner or family member do it as well. What renal procedure do we use during the fluid resuscitation phase to help give the kidneys some support? Geez, I don't have my glasses on. CCRT, I think you mean CRRT, but I would accept that answer. Good job. Let's see. We have circumferential. How's the 3-to-1 rule can be used in? Let's keep it to burns first, and then we'll go to shock. So that way we're not jumping all over. In a circumferential burn of the belly, what are we trying to avoid? What complication?
Compartment syndrome.
Compartment syndrome. And what nursing physical exam or assessment could we do to test for that?
Bladder pressure.
And what's the magic number for bladder pressures?
Less than 20.
Greater than 20.
Greater. Okay.
Anything less than 20 is normal. Let's see. What could we do for a non-healing graft site or a wound bed? What kind of procedure can we prep them for? And it could be inpatient or outpatient. What'd you say?
Yeah, skin graft.
So the skin graft is failing.
Wound vac. Is like a deep wound or just like?
Oh, I'm trying to think my words without giving out the question per se. So this is a inpatient or outpatient procedure that helps with wound healing, either from a burn or a wound.
Oh, HBO.
HBO, yeah. Hyperbaric chamber. So that's when they go into the like deep dive, 100% oxygen. If they catch on fire in there, they're automatically dead. Tell me about discharging a burn patient. What are some education things you guys would want to have your patient know?
Don't smoke on oxygen.
Don't smoke on oxygen. Yes, you'd be surprised. Good job, Haley. Sunscreen. Whoa. I'm sorry, I didn't hear what you
Teach
said.
them to monitor for signs of infection.
Mm-hmm. Wound dressings, protective clothings.
High protein intake.
Yes, diet is really important. Do we use ibuprofen? For burn patients? I know you all are thinking no, and you would be correct. The reason why we don't use ibuprofen is because of the prostaglandin property. It actually inhibits wound healing, so we do something with Tylenol instead if they're having inflammatory issues or fever. Let's talk about frostbite. What are the different types of frostbite?
I got this one this morning. There's frost nip.
Frost nip? And which layer of skin does that involve? Excuse me.
Epidermis.
So frost nip is like walking from our cars to into the hospital. This morning was a little bit nippy. So frost nip. That's just the epidermis, the very superficial layer. Superficial frostbite is the epidermis and the dermis, and then deep is dermis and subcutaneous. Okay. What kind of grafts do we use for burns?
Allograft and autograft.
And where do those come from?
Autograft from the actual patient. Allograft from cadaver.
Mm-hmm. Cindy says xenograft. What's that?
That's from pig.
Yep.
Or
Skin. Porcine is the other name. Fish skin was used in animals only. They're in our country. We don't do cool things like that. Who knows? Maybe in the next 4 years we will. So your 3 grafts for our exam would be auto, xenograft, and allograft. Unless on a TV show. Yeah. TV shows. Let's see. What are some other interventions for burn care? We've talked about pain meds, and we've talked about grafts.
Electrolyte and fluid resuscitation.
Mhm.
That's like an acute.
Supportive therapies.
Want to elevate the arm or leg? Stupid.
Oh, shoot. Sorry, I'm clicking the wrong buttons on here. Let's see. We talked about protein intake being good. When do we refer, say you're the nurse in the ER or at a clinic and you're triaging somebody and they come in with a burn, when would we call for burn criteria referral? Did you guys have to look at the sheet? Say that again?
Isn't it like if the burn's over 20% of an area?
20%, there's a few. Terry's right, major joints. Money makers, so face. Kiddos are an automatic referral. Burns that are 20%, chemical burns, any suspected inhalation burn, peri area, buttocks, those types of things. Let's see. What would you have a huge burn come in and they're intubated. What would your ABGs look like for that initial burn? So think about how our skin, part of our integumentary system, is compromised. Cheyenne for the win. Same with Catherine. Metabolic acidosis. So think about all of the fluid we're going to give. What would our electrolytes be like? We'd have some abnormals. Yep. Low sodium. Maria's got it. Hyperkalemia. Hyponatremia. Good job. And that's due to how much fluid resuscitation we're giving. So we're giving, 8-9 liters throughout the 24 hours. We're going to dilute a lot of things. Do we put ice on burns?
Nope.
No. Why?
It can like make the burn worse.
Yep. Crystallizes. Yep. Don't do butter. Don't do burn cream because we got to scrub it off anyway. It just makes it worse for the patient. Excuse me. All right. Kind of cross over into shock here. Say our patient has, I can't believe your baby's sleeping so well. That's because I drugged her with Benadryl. Just kidding. We've been up since 4:30 this morning, so she literally, okay, so my clinical group had the great idea of doing pajamas, and then so we got popcorn and M&Ms going, and yeah, jammy night. So I'm sure she just passed out from all the M&Ms, so that's fine. It's hot right now, so I did say that, like she was gonna crash our party. Okay, so shock. Hypovolemic shock. Tell me about that. What are some signs and symptoms? Low blood pressure. Why?
Because of some loss of some type of fluid, either blood or due to diarrhea or vomiting.
Exactly. So if you think about your heart as the pump, and when your pump runs dry because the fluid loss, it's going to work harder, but then it's eventually going to like crap out on you. So you'll see the heart rate increase. And as your heart rate increases, your blood pressure is going to start to decrease until fluid resuscitation, or we stop the bleed, or get the nausea and vomiting under control. What would your patient's physical assessment look like with a hypovolemic shock?
Lethargic, maybe changes level of consciousness.
Okay. Anxiety.
Pale skin.
Okay. Tachypnea, fast breathing. All right. Cool skin. What are some of our medications that we can give to treat hypovolemic shock?
Vasopressors.
Isotonic solutions, vasopressors.
If it's from like vomiting, antiemetics.
So our first treatment would be the isotonic fluids, so the normal saline at 30 mils per kg, and then go into your vasopressors if that's not working. Albumin, thank you, Alex. So what does albumin prevent?
Third spacing.
Third spacing, and we can see that in shock and burns. So we've done hypovolemic shock. Let's do cardiac. I don't remember who had a question about cardiac shock. 3-to-1 rules cardiac shock. Okay. So in cardiac shock, what's going on? Someone tell me what's behind that.
The heart can't produce enough output.
Okay. Bailey said it good. Enough volume, but not enough power. So we have a physical pump problem. It could be from cardiac heart failure, congestive heart failure, heart attacks, aortic stenosis, any kind of congenital anomaly. So what are our cardiogenic shock symptoms look like? Tachycardic, impending doom feelings. Yeah, it could also be from a PE, so you could have a little bit of that going on. Hypotension, so low blood pressure. We'll also see the workload of the heart go up, so it's going to be grasping for all of the oxygen to try and promote that through the actual heart muscle. So you'll see a dip in your pulse oximetry. Good. What is a normal MAP?
More than 65.
What did you say?
More than 65.
Yes.
Higher than 65.
Yeah. CHI, Nebraska Med is greater than 65. The only exception is like the CVICU at Nebraska Med or Burn when they play around with those numbers. But anytime you have somebody chronically under 60, for about 20 minutes is when you have cell injury. After 20 minutes, you start to see cell death. If you guys remember from renal that you're only given, 1 million nephrons per kidney. And if you're blowing through them, they're not going to grow back. So then you're going to have chronic kidney problems after that. So that's why we get so anxious when we're like, oh gosh, it's 60. Now it's 58. So we got to lickety split fix that. Cardiogenic, hypovolemic. What am I missing? Let's talk about distributive shocks. So there's a couple different types. Someone name the types of distributive shock.
Septic, anaphylactic, and neurogenic.
Ooh, hot to trot. Okay. Let's start with neurogenic. Do we have a high pulse rate or low pulse rate? Low, good job. And what's their temperature like?
They adapt to the room temperature. And I don't know what's the term. I have no idea. Something with P.
Poikilothermia, I think is the correct term. And what's another complication of neurogenic shock? Happens at T6 or above.
Autonomic reflexia.
Yes. What? We can all message. Okay. Hang on. I'm going to put her down for just a sec. Okay. So the poikilothermia is the where the temperature takes on whatever temperature it is in the environment. So if it's hot in the room, your patient's going to be hot. What else about neurogenic?
You have to be careful with fluid resuscitation not to overload because they don't have a fluid deficit. Is that right?
Say that one more time.
Well, with fluid resuscitation, there's not a need for a lot of fluid.
Correct, because we're not having a fluid volume loss. We're having a spinal cord injury. Perfect. Autonomic dysreflexia. Oh, yes, that's the T6 and above where we have that complication. How do we treat or fix that problem of autonomic dysreflexia? Find the cause. Yep. So this typically happens. Sorry, what was that? Was somebody talking? Autonomic dysreflexia happens when there's maybe a wrinkle under the clothing, or maybe their belt is too tight, or somebody leaves the gate belt on, or the catheter is kinked. Colostomy bag is blocked, or maybe they need to poop or something. What are the symptoms? What would your patient look like when you're doing your physical assessment?
Flush face.
Yeah, sweaty, flushed. Headache is another one.
And decreased heart rate.
Okay. High blood pressure, dizziness. JVD. Good. Anaphylaxis. Let's talk about that one. What are some common things in our facilities or out in the world that cause anaphylaxis? Nuts. Oh, that's funny. It's been a long day and it's Friday. It's fine. Allergens, food, latex, shellfish. Why are we so concerned for shellfish in nursing?
Because of the prep, betadine, iodine.
Iodine. Allergens. So like bee stings, bug bites. We're missing one giant one. I don't think anybody's said it yet.
Latex. Oh, medication.
Medication.
Penicillins?
There we go. Meds, vancomycin. One of the common things that we see with vancomycin, it's tolerated still. And you guys actually might see this up on oncology. It's called red man syndrome. And that's where the patient all of a sudden gets really, really flushed and their face gets red, their body gets hot. And if you give them Benadryl and slow down the infusion, then they tolerate it just fine. So it's kind of in that sensitivity, but red man syndrome goes with vancomycin. Eggs, meds, contrast dye, yeah, all of those. What do we do when we suspect a patient is in anaphylaxis? Like full-blown anaphylaxis. Airway and epi, yep. Yeah, airway and epi. And maybe poop your pants a little bit. Just maybe. ABCs, every time will save you and your patient. Let's see. Okay. Septic shock. We haven't talked about that one. What is septic shock?
Or inflammatory response infection.
Mm-hmm. Yep. How do we treat sepsis?
Antibiotics, fluid resuscitation.
The sepsis 6. Go Bailey. What are sepsis 6? So we've got antibiotics, oxygen,
Blood cultures.
cultures. Okay, what are the other 3? Fluid, urine output. That's 5.
Lactic levels.
Yeah. So one of the byproducts our body makes during infection processes is lactic acid. And if we don't catch that the patient is having some kind of infection, the lactic acidosis will creep up. Normal's typically less than 2, so 2.0. At St. E's, it's you can do the general care sepsis, which is the sepsis 6. But if their lactic acid is over, gosh, I want to say if it's 4 or greater, they have to be admitted to the ICU. And it is a very long, drawn out process to do the critical care sepsis orders. It is continuous blood cultures, lactic acid draws, massive the 30 mils per kilo. It's a lot of fun to do if you only have that patient, but that doesn't happen anymore. You might see lactic acid drawn on oncology too if they suspect a massive infection. When do we give antibiotics? When we suspect we have an infection and we have blood cultures waiting. What do we do first?
After the blood culture.
Blood culture first. And is there a magic time frame once we suspect sepsis?
1 hour.
1 hour. Yep. Good job. Ooh, this is a good one. Oh, you guys will like this. Okay. What types of shock reduce urinary output? Hypovolemic, cardio,
I think they will all reduce because they all lower the blood pressure.
Hypovolemic and cardio for sure. Neurogenics really not a fluid problem, so you're not going to really see that fluid loss. Septic is your other one. Anaphylaxis, not typically, because once you stop the allergen during the fluid resuscitation and the epi, your body usually clears it because the fluid resuscitation helps dilute it.
What about the obstructive one? That one too?
Yep, we'll get to that one soon. Let's see. What does our, did we do anaphylaxis symptoms? What are our anaphylactic symptoms? We talked about airway intervention immediately. But what if it's a slow reaction? Swelling, hives, dizziness, hives, skin rash, anxiety. Yep. You guys are going to do great on Tuesday. And then our obstructive shock. What do you guys think? Got a blockage, so it could be, what are some examples? Tumor, pulmonary embolism, thrombus, a coin. Yeah, some aspiration. What else do I got on here? What is a normal carboxyhemoglobin level?
Less than 15%.
10 to 15. Smoking right now can cause, well, smoking, vaping always causes you problems. Those people tend to have like a carboxyhemoglobin around 10-ish. Because we wear masks all the time, we're starting to see like the more normal trend is around that 15 number. Okay. Carboxyhemoglobin. God, carboxy HTB. What does, speaking of carboxyhemoglobin, because that's a burn question. Say you have an inhalation injury, what is that going to look like with addition to the elevated carboxyhemoglobin? What's your physical assessment findings? Sooty, nose, swelling, sit in the mouth. What about their voice? What's that going to sound like? Harsh, hoarse. We call it crotchety and burn, but you can't chart that. Raspy, that's a good one, raspy. Do you think it'll be painful? Yeah. The swelling will happen in 48 hours, and literally when you do the inline suction, because these patients are intubated, the soot comes out, and so does like chunks of their lungs because it sloughs on the inside. Just as you would expect their skin to slough off, that's what their lung tissue does as well. As you all enjoy your snacks.
How long does that take to heal since it's in the lungs?
It's very dependent on the patient's comorbidities. So this usually happens when someone's smoking on oxygen because, they have their oxygen hooked up and then that oxygen is just blowing right in. It can take anywhere from 2 weeks up to months. Obviously, the younger you are and the more healthy you are, you're going to heal quicker.
Thanks.
Don't smoke on oxygen. Don't smoke in general. That's my theory. I'm looking. What else have we covered? What's the definition of shock?
Reduced tissue perfusion.
Yeah. There's another part to it.
Decreased oxygenation and nutrition.
And impaired cellular metabolism.
Yeah, good job. Ooh, let's talk about MODS. Multi-organ dysfunction syndrome. What is our criteria for MODS? How many body systems have to be involved? 2 plus. Yep. when we see this shift, what does our nursing assessment look like? Detailed. Yes. What are your physical findings? Maybe that's a better way to word it.
They would have
An output. Third spacing. So when we have MODS, typically our first two symptoms to go are cardiac and renal. So we're going to see that decrease in renal perfusion, respiratory distress, terrible labs, terrible ABGs, no, hardly any urine output, DIC, absolutely. Liver dysfunction. It seems like after respiratory and renal start to fail, then it's cardiac, then liver, and it's just a whole thing. Hang on, I have to yell. Sorry. Just the dog needs to go outside. Let me look at this review. What about our kidney labs? Would we see elevations? Decreased?
BUN and creatinine be elevated.
Yep.
MAD is like organ failure, right? So everything that is related to organ failure.
Mm-hmm.
Okay.
Yeah, those are the patients that typically, we say DC to JC is what we call it. They need to go to heaven. Everything fails, and it's like one thing after another, and you can only give so much, and you just chase your tail to try and save these people. And I think the PowerPoint and the lecture or the book was saying 70% to 80% mortality rate. It is very hard to keep these patients alive. All right. What is the term for generalized edema all over the body?
Anasarca.
Mm-hmm. Yeah. ANASARCA. Okay, I think we've hit the highs and lows. We've got about 10 minutes left. Do you guys have any other questions? Any more topics you want clear? And well, I can't give you the test questions per se, but we have, honestly, we've covered 90% of what is going to be on the exam.
Michelle, are the answers to the practice questions posted somewhere?
I can post them when I get off here.
Thank you.
We won't tell anybody if you do. Yeah, right. So this is recorded and it's going to be posted, and I can't. I know this test is going to be make or break for a few of you. And so I really hope this, stop the recording. I really hope this helps you. Don't give up just yet. I'm still adding in points for the burn stuff. You get a point for clinical. So literally you just have to get to that 78% mark, and then you'll get a point added from clinical. So that'll be 79. So just hang in there a little bit longer. See how you do on this exam. You ask about the stages of shock. Let me check my sources. Let me pull up the PowerPoint here. So our PowerPoint has the 3 compensatory. I don't have specific, in stage 1, this is going to be a VQ mismatch. What are your signs and symptoms? I'm not asking that specific of a question. However, NCLEX would differentiate that, or your ATI comp predictor next quarter. But I won't ask, this is the refractory stage, this is the end stage. Let's see, Muse. CHI uses Muse. This is on this one. So what happens is you take your vital signs, your labs are entered, and a calculation is put together based on how fast the patient's breathing, what their labs are, what their blood pressure is, and then it calculates the score. You can kind of see it up here. Oh shoot, I'm not sharing my screen, never mind. This is slide 11 in the shock PowerPoint. Then it gives you this number, and if it's a 0, you don't have to do any extra interventions. If it's a 1, maybe you take their vitals in an hour and see if it was just, they were riled up because they have a nursing exam on Tuesday. Or you come back in an hour and you're like, oh my God, they're getting worse. Maybe I should call my physician. Or do we need to call an RRT? Or holy crap, I need to call a code because this patient's about to go down the drain on me. So it prompts the med surge floors and any floor except the ICU, that some rapid interventions need to be in place quickly, just in case the patient would start to deteriorate. It's supposed to help us pick up on these things. So that's Muse. Sanis CHI uses it, except in the ICU, because a lot of these patients are on hourly vitals or on continuous. And when do you stop the fluid resuscitation? For burns, it's after 24 hours. And then we start the second 24-hour algorithm, but that's beyond our scope for this course. In septic shock resuscitation, it's till your fluids are done, that initial fluid bolus, and then it's going to be provider specific. So your physician will tell you what the next rate is. Good questions.
Michelle, please, can you clarify, you asked a question about which type of shock lower the urine output.
Mm-hmm.
Can you clarify those one? I think we say few, but I know when I say obstructive, you said I was not part of it, right?
So when we're looking at the different reasons why we have low urine output, I'm trying to think of how to word this without giving you guys the answer.
It's okay if you do.
I know, but
Just kidding.
I don't want that to come back on me in 6 months when everybody fails NCLEX because we gave the answers to you. Let me see here. I'm pulling up our shock PowerPoint. So maybe I can word this different for you. So with sepsis, hypovolemic, and cardiogenic, we would have the decreased urine output. And you're asking about the obstructive. Is that what you're trying to say? Why it's not?
I just wanted to make sure that that is what you said, that obstructive was not part
Correct.
of it.
Yes. Beyond
Okay.
that, I can't give you, if I go beyond that, I'm going to give the answer to the test and I can't do that.
So just to clarify, obstructive is not part of it.
Correct. If I give you information beyond that, I'm going to have to throw out that test question and
Oh, okay.
it won't be an
Sorry.
extra credit then. Okay. Oh, sorry, I'm behind on the chat. Do we need to know the London Brower or the rule of nines? There is a question for rule of nines. It says use the rule of nines in the question. And then you'd have to figure out the percentage. And then for the 2 math questions, depending on if you prefer the London Brower or the rules of 9, that's your choice. There is a very clear answer. It's not going to be like 45%, 42%, 44%. It's going to be a range of numbers that you're going to be able to figure out. Does that answer your question, Cindy? I haven't quite decided. I don't know. Maybe someone should buy me a gift. That I'm going to try and figure out how to put the rule of 9 chart into our exam. There's a way to do it. I just have to figure it out. And I've tried and it didn't work last quarter.
What would you like? What would you like?
I'll give you some meal prep containers.
At this point, I like booze. I'm kidding. I'm not old enough to drink. What are you talking about? I will try.
Coming right up.
What did you say?
Gift card to Target coming right up.
There we go. No, I can't take any gifts. I will really try though. Let me think about if I can't get it up there, maybe you guys can like print it on your study sheet or your blank sheet. And I think I'd be okay if you guys had it for this exam. I'll think about it though.
I mean, even then, if we like memorize the chart and then like when the test starts after we show our paper, if we like jot it down real quick, like, is that okay?
Yeah, like brain dump it, like show a piece of paper and then brain dump it onto your blank piece of paper.
Yeah. Cool. That's what I did for the first exam with the ABGs.
Yeah. I still have to practice my ABGs sometimes when I'm floating between a clinic and the ICU. I have to like retrain my brain. Oh, I didn't see that. Oh, okay. Got that. One last minute to go. Any final questions? This will take about 15 minutes to upload. Yes, in my Respondus instructions, it says the student may use a blank piece of paper. They just have to show it and flip it back and forth. So if you just go like this before your exam, you're good to go. Other questions? Do people normally do well on this test? I think so. I mean, personally, I'm like an 80% average student when it comes to my exams. Now, if nursing school was all papers, I'd rock that out. But I have to study my butt off to get an 80%. So I feel like an 80% is a very good average to have a goal to shoot for. You guys got an 82 average with the last exam, so I really think this exam would go a little bit better for most of you. Hopefully, sorry, all of you, it's going to go. Think positively. I don't think anybody failed the exam last time. I want to say the averages was like an 86, so many people did a lot better. Glass is half full of booze. All right. Accurate, yes. I was hoping all of you guys would turn your cameras on so I could at least see your jammies. I'm expecting somebody to have a onesie on. Was that Alex? Alex, where's your onesie? Where,
I forgot my webcam, but I'm gonna take a picture and send it to you.
Oh gosh. All right, jammies, sweatpants. I have Christmas jammies. I don't know if you guys can see these. There's like tigers and stuff.
I've honestly thought